I would now like to invite our Chief Instructor, Reddy sir.
Thank you.
Who is one of the pioneers of teaching about visual fields, and he has authored 2 books on that so far. Please, sir.
Okay. At the onset, my sincere thanks to Scientific Committee to give the instruction course for us. My talk is on interpretation of visual fields related to glaucoma. The aim of interpretation of visual field in a glaucoma suspect is to diagnose glaucoma. And the aim in interpretation of visual field in established case of glaucoma is to set the target IOP depending on the field defect, the location of the field defect, extent of the field defect, depth of the field defect, and the direction of progression of the field defect. Taking into consideration all these things, we set the target IOP and to prevent further progression and to prevent the onset of new field defect. So for this interpretation, you must have proper baseline fields. What do you understand by proper baseline field? Normally when we suspect glaucoma, we ask for 24-2 and we see the indications for 10-2. And the indications of 10-2 starts from disc evaluation and proper evaluation of 24-2. So as you know, the neuroretinal rim, the outer edge is formed from the peripheral fibers, will enter at the outer edge of the neuroretinal rim. And if the field defect starts from the periphery, the disc almost looks normal. And at the maximum, the IS20 rule may be violated. When the defect starts from the center, that means the central fibers are involved, then the notch appears along with RNFL defect. If you see a notch with a RNFL defect, you ask for 10-2. Sometimes we may see glaucoma both starting in the within 10 degrees and outside 10 degrees, and there may be a localized rim loss with a RNFL defect. Now the conventional concept is glaucoma starts from the periphery and progresses towards fixation. Where it involves the fixation, then we ask for 10-2. In 2011, when this patient came and with a mean deviation of -5, I took the patient lightly and started the treatment, and then I did not test the 10-2. When the patient came in 2012, there is a notch, there is a nerve fiber layer defect, and there is a absolute scotoma on the 3-degree point. When I took the 10-2, there is a huge scotoma with a mean deviation of -7, more than what the mean deviation of 24-2. Then I realized the glaucoma can start within 10 degrees. Then if I see a notch and an RNFL defect, even though there is no gross reduction in the central 16 points, even though there is the localized scotoma, one scotoma is there, not fulfilling Anderson's criteria, yet I ask for 10-2 and we can see the huge scotomas in 10-2. This patient under my care from 2005 to 2007, a localized scotoma. I thought that the patient is stable, and in 2015, when the patient is complaining that I am not seeing near vision properly, then I saw the absolute scotoma is there from the beginning. When I asked for 10-2, there is a scotoma passing in between 3-degree point and 9-degree point, not picked up, but actually I will tell the grayscale role, then I realized there can be multicentric origin of glaucoma. Then how we should not miss multicentric glaucoma? The main culprit is total deviation probability plot. If you see the total deviation probability plot, it is looking like a single scotoma biarcade, but if you see the pattern plot, it is having 2 scotomas, one at the center and at the periphery, and also a grayscale also will tell us one is at the center and another is at the periphery. So if you follow the grayscale and pattern deviation probability plot, you can pick up multicentric origin of glaucoma. But sometimes the total deviation, pattern deviations may look similar, but the grayscale will help us to pick up the multicentric origin of glaucomas. So why? Because why we should have proper baseline fields? Take for example, sometimes the glaucoma may be stable in 24-2, maybe show progression in 10-2. So we must have proper baseline fields. And the main culprit is the grayscale. Normally the grayscale within 10 degrees, it should be bright, because the sensitivity in the central points are more than around 38, 40, and just outside 10 degrees, it is around 30. Even though the central area loses 10 dB, there won't be any darkness in the central area. That is the main culprit. So losing brightness within the 10 degrees is an indication to repeat the test. Even though there is no gross reduction in the sensitivity of the central 16 points, and if you see the fundus, you will have the RNFL defect going towards the macula, and OCT also will help us. You see in the case, the 2, there is a shade, the darkness little appeared, and in the last case, the darkness came in the center. So we should not wait till the dark shade appears in the grayscale. Appreciating the losing the brightness within the 10 degrees is an early indication to repeat the test of 10-2. So in order to, when the 24-2 came into existence, not to miss, to ask for 10-2. You please remember, 24-2 is not the substitute for 10-2, because we are not finding any points within 3 degrees. Even 24-2, no points are there within 3 degrees. Therefore, for macular split, fixation split, we have to ask 10-2. And this is the case, the pre-perimetric glaucoma, almost the strong family history or IOP are little higher side. If you see the 3 cases, almost the discs are looking similar, but suspected glaucoma. And somewhere in the first case, somewhere it is told as a physiological cup, and in 2016 and 2016, she came in advanced stage. And 2017, 2019 came with a disc hemorrhage. 2019, the third case seen, and 2024, it came in an advanced stage. So it is very, very important to pick up the early glaucoma at this stage, because in most of these cases, the field defect, if it appears at the periphery, almost they look normal. At the maximum, I told you the IC207 rule. So the perimetric classification, this is my own classification. Glaucoma can be classified as pre-perimetric and perimetric. Perimetric can be starting from outside 10 degrees, within 10 degrees, and simultaneously within and outside 10 degrees. If you follow this classification, you hardly miss the indications of complete 10-2 and 24-2 simultaneous to have the proper baseline fields. So the pre-perimetric glaucoma, there is no field defect. When there is no field defect, there is no role of visual field. Visual field only tells when there is a field defect. Now the perimetric glaucoma. The perimetric glaucoma, interpretation of the perimetric glaucoma can be done in 2 ways. One, analyzing the field defect. That is done by the visual field, the field analyzer. But the normal field is there in the perimetric glaucoma. I gave a new terminology. To the normal field, I told that it is a pre-perimetric part of perimetric glaucoma. This pre-perimetric part of perimetric glaucoma will be analyzed by OCT. So to take, for example, in the first case, localized scotoma, it is the established case. We can see RNFL with rim, and there is a well-done field, fixation losses, false positives, false negatives are almost within normal limits. When the false positives exceed 15%, that is an indication to repeat the test out of these 3. So this is most alarming about the field defect is, it is a relative scotoma, but it is progressing towards fixation. When it is progressing towards fixation, you must be alert in the management of this case, even though it is a relative scotoma. The second case is a well-done field. It is a biarcate scotoma, and if you see the scotoma, there is a definite indication of 10-2. The 10-2 is done. If you see, they are all absolute scotomas. The upper field is almost absolute scotoma. So once it became absolute scotoma, there is nothing to do with that field. Now our aim is how to protect the maculopapular bundle and the lower field. So when it is normal, we have to take the help of OCT. So OCT, the upper part reflects the lower one, 63, 69 and 71. 71 is the maculopapular bundle. See the upper temporal, which reflects the lower temporal field, almost it reaches the red zone. So you must be very aggressive in the treatment, and to save the lower, you can save only the lower part. So we have to go for trabeculectomy to keep the pressures very low to save the eye. So normally when you see 10-2 in this case, for progression analysis, you need not go again for 10-2. You can go for macular test, because you have to know how the maculopapular bundle area you assess. You can go straight away to the macular program with size 3, which is most underused. Then this case is a localized scotoma, and with a mean deviation of only minus 2.29. But when the test is repeated with 10-2, see the mean deviation is minus 12. And luckily, the lower part is having a very good retinal ganglion cell thickness. You need not be so aggressive in this case to save the remaining vision. This patient, if you see the next case, appearing, if you analyze, it is looking a localized scotoma. But this localized scotoma, if you don't analyze properly, you think that it is starting from the periphery. But if you see analyze the localized scotoma and see the raw data, the total deviation numerical plot, it is actually absolute scotoma on 3 degree. And when repeated the test, it is almost absolute scotoma nearing almost to from the fixation. So in this case, the lower field is also 77, 71, 68. So we should be very alert to save the eye, because the upper field is almost gone. And this localized scotoma you see, actually this localized scotoma, if you don't see properly, you may think that the glaucoma started from the periphery. But if you see, analyze the field, this see raw data or total deviation numerical plot, on the 9 degree point, it is minus 34. That means the glaucoma started almost within 10 degrees. And when I repeated the test in 2018, there is upper arcade scotoma in the 10 degree. And because of the COVID, in spite of taking the treatment, he never came for follow-up. In 2000, after 5 years when he came, you see the upper relative scotoma, what we saw in 2018, became absolute in 2023. And we see, so when you see even a relative field defect and starting from the center, you should be very alert and treat the case very aggressively. In this case, luckily, the macular ganglion macular thickness, GCC complex, is very good at 75, 77 and 73. So, as you know, by this time you must be knowing the glaucomas can start within 10 degrees, outside 10 degrees and simultaneously. You see the glaucoma starting from the periphery, the first one, the disc looks very pale. And when the glaucoma starts from the center, the disc looks almost very healthy, because most of the peripheral fibers are intact. Even if you see GCC, the ganglion cell analysis OCT, you see the 78, 87, 88, the peripheral fibers are good, whereas in the glaucoma starting from the periphery becoming advanced, most of the fibers are atrophic, and we see the appearance of the pale disc. This is the first case in 2012 I saw. See, I maintained actually this localized scotoma almost stable in 2012 what I see, and 2024 what I am seeing now. Actually, I did trabeculectomy at the very early stage. And if you see the dangerous, even though the pre-perimetric part of perimetric glaucoma normal zone, the GCC thickness are 51, 57, and 83. So she's, in spite of doing trabeculectomy, I put the patient on one drug, and luckily she is maintaining the whatever the existing vision she had. Now, what is the role of, as you know, there is no role of visual field in the perimetric glaucoma, and the most important is the Panama analysis. The Panama analysis means whenever you, suppose in visual fields, we ask for indication for 10-2. When you see OCT, we have to ask both RNFL printout and GCC printout. Then the thickness map and deviation map of both RNFL and GCC, the combined report will be there in the Panama, which is very important what we see here. Panama, GCA, RNFL thinning pattern. Even though it is all green, and in the Panama you can see the arcade pattern. That is the main indication to diagnose glaucoma, in a glaucoma suspect. That is actually glaucoma, perimetric glaucoma, green. This case, the visual fields are normal. RNFL and GCA only yellow color code, and definite pattern field defect, pattern thinning is there, and this is known as pre-perimetric glaucoma, yellow. This patient, what we seen recently only 2024 with a strong family history, and there is no field defect even in 24-or 10-2, and RNFL is normal, all green. But GCA is showing 66. You see, the most important point what I want to tell you is, even though the ganglion cell thickness is having a red color code, 66, still the field will be normal. The red color code GCC thickness with 66, the field is normal. And the red color code appears from 68. Almost up to 60 degree micron, the field will be normal. That is why minimum 30% ganglion cell loss should be there to appear for this thing. And the same patient, in 6 months' time, developed the pattern thinning in the thickness map and deviation map, and still the field is normal. So the most important thing, take-home message is, in glaucoma suspect, the Panama analysis, the thinning is very important to pick up pre-perimetric glaucoma. My namaskars to all glaucoma patients from whom I acquired this knowledge. Thank you for your patient hearing.